Hello, I'm Baxter. I'm a GP from London, and I'm going to take you through this asthma right care presentation about the chest infection. So this is a story which looks at a fairly typical presentation in general practice where a patient comes with a description that is not necessarily one of an asthma attack. They may describe it differently. In the UK, we often hear people coming saying, I've got a bit of a chest infection, or I've got a bit of bronchitis, doctor. This can put us a little bit off the scent of what really might be going on, and so there is a real opportunity here to listen carefully and to explore carefully with the patient what their symptoms might be today and what you might be able to do to really help them. So this presentation has been developed with colleagues that are part of the Asthma Right Care group within International Primary Care Respiratory Group, and we are grateful for the funding that we've received from AstraZeneca for this project, this social movement. So let's go to the next slide. Please feel free to use these slides to adapt them for your local situation, to use with your colleagues, so that this particular educational tool can be used more locally as well. And when you do use them, if you can just say where they came from, and that this was developed by myself, Dr. Baxter, on behalf of the Asthma Right Care team. So what I'm hoping that you will learn during this session is why somebody presenting with an acute episode of breathlessness with a suspected or unclear diagnosis or poor understanding of asthma is an opportunity worth spending time on. It's possible that we do go down the road of listening to what the patient has said and not really listening carefully to what's underneath it. So it's an opportunity to think about what you could do differently. We need to think about, and we will learn why antibiotics don't always have to be given just in case. I think there is a common misconception that the asthma attack may have been triggered by an infection, and therefore it is worthwhile giving an antibiotic. I hope at the end of this you will also learn how to distinguish between and feel confident about what is asthma and what is a lung infection, because they are two different things, but I think sometimes we end up treating them almost the same with too many things and not really focusing on what the problem is. And importantly, this is an Asthma Right Care project, and we want to help you to avoid doing asthma wrong care. So doing the wrong things when somebody presents with asthma, which can cause problems down the line and make care less good for the patient. So, who is the patient? So it's Sharon. She's a 33-year-old woman. She is a classroom assistant at a primary school, and therefore she's exposed, especially during the winter months in the UK, with lots and lots of viruses from children in her class. She has a complicated life. She is a single parent. She has 2 children, and she has suffered domestic violence in the past. So while she's a single parent, there is a male partner who is still around, and so she's potentially at risk. So I'm telling you this because asthma is not the biggest problem in her world. There are other issues which are very important, and therefore we need to think about the amount of headspace that she's got available to consider her asthma and what other things are going on for her. So how can we help her do the right thing for her physical health, despite a lot going on psychosocially? As is often the case, there is a family history of probable asthma. So her children, who are aged 5 and 8, both also use salbutamol. This doesn't necessarily mean that they've got asthma, as we often see children with unclear diagnoses, or maybe they're too young to be absolutely clear about the diagnosis, who may be using salbutamol. And as is often the case in a family from a lower socioeconomic group, there may well be an older member of the family who has got chronic obstructive pulmonary disease. And in this case, her mother has an asthma diagnosis and has also been told that she's got emphysema. What else can we tell you about Sharon? So she has a diagnosis of asthma. It is managed with inhaled corticosteroid, so that's her preventer, and she uses salbutamol as needed. So that's her management plan. Her asthma was diagnosed at an emergency department visit when she was 8 years old, and she first received salbutamol at age 3 years. So she's had quite a long history of having problems with breathing. In the last 12 months, she has received 14 salbutamol inhalers. Her last inhaled corticosteroid inhaler was issued 2 years ago. So this isn't looking great. She has received 5 courses of antibiotics in the last 3 years for respiratory conditions. Her blood eosinophil level over the last 2 years, when her full blood count has been taken for other reasons, has been 0.3, 0.4 and 0.3. So you've heard a little bit about Sharon, and let's think about what is coming up about this case and how it relates to what we know in the environment and what evidence is available. So SABA, short-acting bronchodilator, beta agonist is the BA. Overuse or over-reliance is an indicator of poor control. So in the United Kingdom, there was a national review of asthma deaths from 2012 to 2013. There were about between 1,000 and 2,000 deaths. We often talk about there being about 2,000 deaths per year in the UK. We didn't see all of the notes. It was a review of a sample of notes that became available. And 39% of people who were on short-acting beta agonists at the time of death had been prescribed more than 12 in the year before they died. So let's just remember that Sharon's had 14 in the last year. So you can see that's immediately putting into high-risk category. 4% of people from the National Review of Asthma Death had been prescribed more than 50 SABA inhalers. That's a huge amount. Those prescribed more than 12 were likely to have had a poorly controlled asthma. So this is a bit of a red flag for us that we need to consider. Again, this study showed that there is a progressive risk of hospital admission associated with the prescription of more than 3 SABA inhalers a year. So the Asthma Death Review talked about 12, but what we're seeing here, that there is a sliding scale of more use of SABA means more risk of increased healthcare utilisation and poor outcomes. So we can see here at 1 to 3 inhalers, 20 patient episodes, 4 to 12 inhalers, 33 patient episodes. There's a much smaller sample size in the greater than 13, which is explains why there is a much smaller number of inpatient episodes. But you can see that the problem gets worse as you have more use of SABA inhalers. So, what can we do about it? Well, there is some evidence that electronic alerts can reduce the excessive prescribing of SABAs, but only as part of a more integrated health approach. So in this study here, from Shauna McKibben and published in Primary Care Respiratory Medicine, we can see the results of the number of studies that have been done to have a look at whether or not there is any impact of electronic alerts. What you can see in study 1 is that they found no effect of the alert system on the prescribing of inhaled corticosteroid. In the second study, similar picture. In the third study, they saw that an alert seemed to have an impact on the prescribing of more short-acting beta agonists. Didn't have an effect on inhaled corticosteroids, but it did seem to have an effect on a combination of long-acting beta agonist and inhaled corticosteroid. And in study 4, we're again seeing no effect on inhaled corticosteroid prescribing on its own, but we are seeing an effect there of inhaled corticosteroid in conjunction with a short-acting beta agonist. So it's worth thinking about whether or not, if we alert ourselves to the presence of over-reliance or overuse of short-acting bronchodilators, then maybe there's something that we can do about that and we can have an impact. So let's have a look at this next paper, and this is from Reddell, who is an asthma specialist in Australia. So what's happened here is that they have found that 1/4 of the reliever-only population had needed urgent asthma healthcare in the previous year, demonstrating the importance of identifying such patients. So this was a cross-sectional population internet study which was done in Australia. So they've done a survey to see what the 2,686 adult participants were doing. And what we can see from the graph here, so on the y-axis, the higher the bar, the more likely it is that you're using more reliever, and you're using reliever alone for managing your asthma. So what you can see here is that the higher the amount of use of reliever-only medicine, so in our first criteria, where somebody was seeking any urgent health care, we can see that where there was 42% of reliever-only use, there was a high proportion of not well or very poorly controlled asthma. If there was a low proportion of reliever-only, so in this particular category it was just over 10%, then they tended to have well-controlled asthma. If we then have a look at the other criteria, so whether they were seeing an urgent GP appointment, or whether they were going to the emergency department specifically, or whether they needed a hospital stay, you can see that for every category, those patients who are using reliever only as their main management plan for asthma were more represented in the people having urgent care, regardless of the setting that they were in. So, poor adherence to maintenance pharmacotherapy, which generally speaking we're talking about inhaled corticosteroid, but it may also be leukotriene receptor antagonists as well, is an absolute reality in asthma, and anyone who's a practicing clinician will recognise everything that I've said so far, which is that people are more likely to tend to use their reliever inhaler, and they really struggle with sticking with their maintenance prevention therapy. There is a switch in recommendation in the current guidelines from step 1, which was always use a SABA as needed, to step 2, which is always to use an inhaled corticosteroid fixed dose regimen and minimise SABA use. This particular review here from the European Respiratory Journal suggests that the medication that treats the underlying disease, which patients are encouraged to take, and all of you encourage your patients to take, which is the inhaled corticosteroid, is not the one that the patient perceives as benefiting them. They think the short-acting beta agonist is the thing that's really working. And we're now trying to get to a position with our guidelines, which have been updated in the last few years, that we need to be starting with prevention and not starting with reliever. So it's a very different change in attitude here, but I think what we have to be aware of is that this is a change in behaviour, whereas there is a culture over many, many decades of people tending to use reliever and not preventer. So this isn't going to change overnight. So let's go back to Sharon. So you know about her, you know about her background. We're talking now about her coming into the surgery today. So she's booked an emergency appointment, having taken her children to school. So what we're picking up on there is her priority is still her children, and then once she's dealt with them, she can start thinking about her own health. She arrives, she's feeling stressed because actually she should be at work. As I told you already, she works in a school as a classroom assistant, so therefore her children are going to school. That's probably where she should be too. And so she's worried about that. And so she wants to get in and out and get something that's going to make her better pretty quickly. So she needs her inhaler because that's what she thinks is the problem. It's empty again, and it's empty again because she has been overusing it probably. But actually we need to find out what she means by her inhaler, don't we? And she also thinks she needs her antibiotics as she is chesty. So for those of you that aren't from the UK, chesty is a description that somebody from the UK who speaks English as a first language may well use to describe their respiratory symptom. And it probably represents chest tightness, a feeling of breathlessness, and maybe a cough as well. It may mean something different for different people. So this is now me trying to get into your mind, thinking about what you might be thinking in this situation. So she's your patient, and you see them on a fairly regular basis because you're a general practitioner or somebody else, a healthcare professional working in primary care. And you get to know families. Usually when you see her, it's normally a psychosocial issue. It's about her mood, it's about the behaviour of her children at home, it's about what's going on with her relationship, with her housing, these sorts of things. And you're pretty sure that she doesn't have time to make her own physical health a priority. So that's Sharon. What's going on for you? Well, as is often the case, I'm sure, you're having a busy surgery. This is in the middle of winter, so it's particularly busy with coughs, with colds, with requests for antibiotics, and you've got 3 home visit requests because somebody's got flu. So you're feeling pretty pressurised, and I think both of you are wanting to move this consultation on as quickly and as efficiently as possible so that you can both get on with what else you need to do. So you think, well, Sharon seems to know what she wants. She wants antibiotics, she wants an inhaler, she seems busy, I don't want to stress her. If she has a chest infection, which she might have, then if I give her an inhaler and I give her an antibiotics, then it will cover all bases. So you're kind of thinking you're doing the right thing. But is it really asthma right care? So this is a bit of a challenge because there's what might be easy to do and there's what is the right thing to do. And we're all good on some days and not so good on other days. So let's think about this a little bit more. So we've talked about what does Sharon mean by her inhaler. So you need to think about how you're going to find that out. Is there a clinical case for antibiotics? What information do you already have? Or what other information are you going to need before you make a decision about this? And does she actually have asthma? So I've given you some information already, but I'm asking you, if you're doing asthma right care, to always consider what is it today? What's the evidence for her asthma diagnosis? Just because they have a SABA inhaler, does it really mean that they've got asthma? So something to have a think about. So if you're looking at this presentation in a group, you may want to stop at this point. You may think about in the group what you would do in this particular situation with Sharon around what her inhaler is, what's the case for antibiotics, and what you might want to do to be absolutely sure about the diagnosis of asthma that might be being flared up today. So maybe take a minute out just to have a think about that. And I'm going to move on to the next slide. Okay, so here are some things that I think we have to have if we're going to do asthma right care. In fact, this isn't just asthma right care, this is good care for anyone presenting acutely unwell at your surgery. So we need to know a respiratory rate, a pulse, a temperature, a blood pressure, pulse oximetry, and body mass index. The first 5 of those would all be considered vital signs, but I think the additional one, the body mass index, is also really important. So Sharon is a young person. The probability of her having, let's say, a malignancy is relatively low, but one of the key red flags for detecting respiratory malignancy is whether or not there's a change in somebody's weight. So I think it's pretty important to always think about whether we're measuring this thing as well as the vital signs. I often find that when I look at notes and someone's told me about a weight change, I might find it difficult to find a previous weight, and this makes it very hard for me to make an assessment of the relative risk for something more serious. So let's focus in on what her vital signs showed. So her respiratory rate was 20 breaths per minute, which doesn't hit the criteria for sepsis or particularly severe, but she's a young woman, and actually maybe her respiratory rate is normally around 12 or 14. Her pulse is 98 beats a minute. Again, I think that's pretty fast for somebody, but she's quite stressed. She may have just had some short-acting beta agonist, and this may have impacted on her pulse rate. She doesn't have a temperature, so let's think about that in the context of whether we're giving antibiotics. Her blood pressure is 108/70, something I think would be considered normal for a woman of her age, and her pulse oximetry is 97%. Her body mass index is 24, which sits within the normal range. Some other tests that we can do in the surgery if we decide we're going to make some time for it. So her predicted peak flow is 487 litres a minute, and I've been able to calculate her predicted peak flow because when I measured her body mass index, I had to get a height for that, and obviously putting a height into the equation allows me to get a predicted level. Now, of course, Sharon may well have a best ever peak expiratory flow rate, and you may want to use that in terms of thinking how she is today. So I did her peak flow, and before giving her a bronchodilator, it was 260 litres a minute. So as you can see there, it's a lot lower than what her predicted might be. With a microspirometer, which is also a very quick and easy tool to use and a relatively cheap way of doing basic spirometry, we can see that her forced expiratory volume in 1 second is 1.35, and the predicted would be 3.01. So again, we're seeing that there seems to be some evidence here, assuming her technique is pretty good, that she's got significant airways obstruction today. The other thing that I personally do in practice, because people who do badly with asthma are often people who smoke tobacco or smoke other substances, I check a carbon monoxide because that helps me with my long-term management plan and provides people with information that may help them to motivate them to change. So in this case, her exhale carbon monoxide was 21 parts per million, so that's something that I would also want to explore with her further, because this could represent somebody who is a heavy smoker. So what are the reasons for poor asthma control? Because it's looking like, with Sharon, this is what we're at. So it could be that we've got the diagnosis wrong. It could be that there's something else going on at the moment. It could be that we've given her an inhaler that she doesn't like using or she can't use, or the technique has never been checked and she's trying her hardest but she's not doing it right. It could be that they're smoking. People also with rhinitis are more likely to have poorer asthma control. Non-adherence, so not taking preventer therapy, that might be quite intentional. There may be a fear of steroids and what that might be doing to the body, or it may be unintentional. She's just too busy with life, too much else going on, and asthma prevention is right down the bottom of her list. And there may also be an individual variation in treatment response. So if we've considered that they're taking the treatment correctly, that they're not smoking, there's no other conditions going on, and we know that they're adherent to therapy, then we may need to think about whether this is a type of asthma that needs a more specialist opinion. Usually that's not the case, but there will be some, and so we always have to think about that. And it's just possible that she's on the wrong treatment level for her asthma. So let's just go back there because I went onto another screen. So she may be undertreated. So she may be on a low dose of ICS. It's possible she needs addition of a leukotriene receptor antagonist, a long-acting bronchodilator, beta agonist. So she may just need something else as well. So this could be the reason. So we've talked to Sharon. We've got some vital signs. We've got some basic tests. What are we going to do in terms of the examination? Well, there's some basic things that you always want to do. We need to check the trachea is central, and many of you will realise we're putting that one in because of the risk of pneumothorax and particularly tension pneumothorax. It's always a good idea to feel around the neck. Is there any other reason why this person may be having worsening of respiratory symptoms? Do they have a lymphadenopathy that might suggest tuberculosis, might suggest particularly bad infection, might suggest tumours? So easy to do, and you can very quickly pick up something if it is there. We will listen to the chest, and in this particular case, in Sharon's case, her chest was resonant throughout, and on both sides, but on both sides we could also hear some expiratory wheeze. Importantly, there were no focal or unilateral signs. So again, we're moving in a direction where somebody doesn't have a high temperature, has bilateral wheeze, doesn't seem to have any evidence of consolidation or infection. So we're really probably looking increasingly like this is an asthma attack. So let's go back to what her presentation was. Doc, I feel chesty, I think I've got a bit of a chest infection. So let's explore that a little bit. So what are we going to say to her? So these are some of the things that I may challenge her with, and the sort of responses I might get. But again, if you're looking at this presentation in a group, you may want to have a think about right now what's going to happen in this sort of situation for you locally with the population that you look after. So if I say to her, why do you think this is a chest infection? She may tell me, well, I always get antibiotics. And I told you earlier on that she's had 5 lots of antibiotics in the last year. She might say, well, I have a cough. Cough equals antibiotics. She feels like she's got something on her chest. And we all know that chest tightness can feel like there's something actually physically in there. People will touch their sternum. They will say, I feel I need to get something cleared. They think it's probably mucus. And they think, therefore, if it's mucus, it must be infection. And then also, she might say, even if it's just a cold, it's still an infection, isn't it? Why wouldn't I want to get something for that? So I can see why she might think these things, and these are all reasonable things to raise, especially if her experience in the past has been she's always received antibiotics in response to this. So at this point, let's just move away from Sharon and think about some of the materials that we've developed as part of the Asthma Right Care program. So in the previous slide, I've come up with a question that I'm going to ask Sharon. Why do you think it's a chest infection? And what that is going to do, it's going to provide a discussion. It's going to provide a conversation that might help me to understand a bit more about Sharon, and it might help Sharon to understand a bit more about what she thinks about her condition and what might work best for her to be helped. So this is very similar what we're doing with the patient to what we've done when we've developed the question cards. So these are questions and challenge cards to start conversations. And hopefully, if you are doing this as part of a group today, then you may want to have a look at some of these cards and think about what sort of stuff comes up between you when you start having this conversation. And it doesn't matter who you are. You can be someone who suffers from asthma. You can be a relative of somebody that suffers from asthma. You can be a doctor, a nurse, a pharmacist. So there are various people who can use this card that may help them to think about how they are going to have a conversation about asthma. So as you can see, the first challenging statement that we've got here, the fourth card along on the right hand side of the screen. So health professionals do not invest enough time in educating patients about asthma because they think it's easy to find the information elsewhere and they don't have the time. Okay, so there's a little bit of that going on in this particular case presentation about Sharon. So what do you think about that? Imagine having a conversation with colleagues, with patients. What do you think might come up in that situation? So that's what we would like you to do, and we recommend to you as the Asthma Right Care Group to think about how you may explore some preconceived ideas, some unchallenged thinking about asthma. So let's go back to Sharon. So I think I need to help her to reframe a little bit. She's come in, she's stressed, she needs to get something, go away, get better, carry on with her quite difficult life. So what might you say? So I'm going to tell you what I might say, but you may want to think in your group what you might want to say. So I could say to her, I can help today, but I don't think it's the infection that is causing you to feel this way. I'd like to help you understand. Do you have the time? So I'm offering her the opportunity to explore this a little bit further. I'm kind of holding up my hand, saying, let's just slow down, take the opportunity to do it differently this time, because it may help in the future. And I can say to her, I also think I know a way that I can help you save you time, prevent this happening in the future. So a little bit more time now means a little bit less time needing to come and see the doctor, go to the emergency department, etc. in the future. So there are questions that you can ask. These are ones that I've come up with, but it might be worthwhile you just in your own setting thinking about what sort of questions you would want to come up with too. So I just want to bring in here the issue around antibiotic stewardship, and I'm sure that all of you will be getting messages from your public health departments, from your national health departments around the responsibility of being more careful and being more thoughtful about the prescribing of antibiotics. So I have a responsibility here. As you can see, that I don't think she's got a chest infection, so I need to challenge that a little bit more. So I've got some things that I say to help have that discussion about no antibiotics. You personally or in your group today may come up with some of your own ideas. So for me, I would say to her, you're right that your cold has triggered how you feel today, because we know that viruses trigger asthma, but antibiotics won't treat a cold, and they won't treat what is happening inside your airways right now. So if the virus has triggered an inflammatory response in her airway, then there's nothing I can do about that by giving her antibacterials. Now, some antibacterials are anti-inflammatory, so putting that aside, it's not really the right treatment for asthma. And importantly, and I think this may well resonate with someone like Sharon, is that at some point in the future you may need antibiotics to save your life. I think this is quite an effective conversation that we can have with people, helping them to realise that their own personal use of antibiotics impacts on how well they work in the future. So it's not just about everybody using them, but it's also you personally. So explaining to her today is not the day where you really need them, but I'm holding them back for when you really need it in the future, but also for your children in the future. So, one of the other questions that I suggested we need to look at, does Sharon have asthma? So, it was made in childhood and it may warrant a review, because if she's now in her 20s or 30s, we didn't have a lot of the testing that was available, back in the 80s, possibly when she may well have been diagnosed. It's unlikely that spirometry would have been available. Pheno hadn't even been thought of, I guess, and you may or may not have been using peak flow diaries. They were available, but I don't know how well they were used. So I think it's important just to quickly go back into the records if you have them. Clearly that's going to be country dependent. I know that in some countries there isn't that kind of continuous care note, but if there is, that's an option. What can you do now? She's presenting unwell with her peak flow, her forced expiratory volume, her wheeze. They're all telling you that there's some airways obstruction. Is this an opportunity, while she's got airways obstruction, to give her something that will reverse it immediately? So that's the short-acting beta agonist, and then measure the response. That will really help you feel more convinced about your diagnosis of an asthma attack or an acute asthma flare-up, and it will also help her because she'll be able to see the numbers too. So it's possible to do it very easily in practice. I personally think it's a good idea for a practice to have a stock of large volume spacers and some salbutamol, so that if we have a patient who's presenting, not only can we measure whether there's any reversibility there and then, but we can also then give that person the spacer and the salbutamol to go away with, because then they've got something that they can use in emergency, because you've proven reversibility, you've shown them how to use it, and you've given them something that they can take away and use in the future when they have a further asthma attack. So let's move on to reflect on what the guidelines are at the moment. So this is GINA 2018 guidelines for the diagnosis of asthma. There has been a 29 update to GINA, but this still holds. So a clear algorithm that you can work through to consider whether or not somebody has asthma. And it's really important, if we go down to the second blue box, that you get a very detailed history. Examination is important, but actually so much of your diagnosis of asthma is going to be based on the key features of asthma. So that's going to be the reversibility, the variability of the symptoms that they're getting, clear triggers, possibility of allergy, is there a family history, is there really anything else that it could be, thinking about what's the probability of this being asthma. So what GINA recommends is that if you've got a very good history, then you can go ahead and you can see whether or not giving inhaled corticosteroids is going to reverse the inflammation and improve their symptoms. If you're less sure, then and the situation is not clinically urgent, then you can do spirometry, and you can do peak flow diaries, and you can look for evidence of reversibility in those, and you can look for evidence of airways obstruction in those as well. You can, if you're not getting positive results, let's say with your spirometry, continue on to do a confirmation of asthma diagnosis with a trial of treatment, because we know that in a lot of cases spirometry will be normal in somebody with asthma. So a normal spirometry does not rule out asthma, and you may need to continue your trial of treatment. It all depends on what you've got available to you, how often you're seeing the patient. So you will have to treat the diagnostic process very individually with every patient who you think may have asthma. And I think importantly, working with somebody who you think might have asthma by saying, listen, I think there's a good probability of asthma. We can see whether or not it is by doing some tests, by seeing if you respond to treatment, and working with them, keeping them on board, because I think if they understand that you're exploring why they have their symptoms, working with them to try and get to a conclusion, then it's much more likely they're going to really believe they've got asthma and then take the treatment that you recommend at the end of the day. So what is spirometry? Well, spirometry, and I'm sure many of you will know this already, measures the airflow and it measures lung volume. two things are really important in order to decide whether or not airways obstruction is present. It's a great test for asthma in primary care, but it takes time and not everybody will have a device. And it is possible, if they're not symptomatic enough on the day that you see them, they may well have normal spirometry. So it's one test that can help you in your jigsaw puzzle that you put together to help convince yourself and then convince your patient that they may have asthma. And what does it measure? So it measures the forced vital capacity. So that's the volume of air exhaled after full inspiration and full exhalation. It measures the expiratory volume in 1 second, and it can be a forced manoeuvre or it can be a relaxed manoeuvre. So how much air do you push out of your lungs in 1 second? And then you can calculate the ratio of the forced volume in 1 second over the forced vital capacity, and that gives you a percentage or a ratio that tells you whether or not somebody has got airways obstruction or not. From this particular graph here, you can see what the sort of spirometric patterns that we may get. So with obstruction, which is something you get in COPD and asthma most commonly, you see a reduced ratio of FEV1 over FVC. Basically, it's taking longer for them to get air out of their lungs in 1 second than it should, and therefore that gives you a lower ratio. You tend to find in obstruction a normal forced vital capacity, and you'll find the FEV1 is reduced. As I said, it's taking longer to get that air out of your lungs, and so that volume at 1 second will be less. In restriction, so when the lungs are a bit squeezed, either by a chest wall problem, by fibrosis in the lungs, or indeed obesity around the lungs, you may well find that the ratio is normal. You will find a reduced vital capacity because the lungs just aren't able to inflate so much, and therefore that large volume, the vital capacity, is reduced. And you may find that there is a reduction in the FEV1, but it can also be normal as well. And of course, it is possible to have a mixture of different patterns. You can have more than one condition. You may have COPD causing obstruction, but you may have considerable obesity causing restriction. So sometimes it can be a pretty tricky picture, and you may find in some situations you have a low ratio, you have a low vital capacity, and you have a low FEV1. So spirometry is one measure. It gives us some information, but it doesn't always give us the answer. It's part of the information that helps us put our diagnosis together. So, a quick spirometry assessment. So, on this slide here, developed by Wonka, so an organisation for people working in general practice, this is to kind of help us just to kind of work through the thinking here very quickly. We're not lung physiologists, so we need some basic instructions. So I've told you before that one of the key measurements is the ratio of the FEV1 to the forced vital capacity. Essentially, if it is greater than 70%, then we can say that it's normal in terms of there is no obstruction. If it is less than 70%, then it is suggesting that there is obstruction. You then go on to have a look at your forced vital capacity, and we're using here a cutoff figure of 80%. If it is more than 80% or equal to 80%, then you're probably looking at mainly an obstruction picture if your FEV1 over FVC ratio is also less than 70%. If you've got a normal ratio and your forced vital capacity is less than 80%, then you're looking at kind of restriction picture. So what you can see here is that by doing your two basic measurements, your FEV1, your FVC, looking at your ratio, looking at the values of each, you can come up with 5 different pictures which helps you with your diagnostic process. So it can be normal, you may have restriction, and restriction always needs further investigation, further thinking about what might be going on. It can be obstruction, and therefore you're in the realms of thinking about whether it's asthma or COPD predominantly. And then you've got the slightly more complicated areas of obstruction and hyperinflation and obstruction and restriction. And I would say that in the areas where it's a bit more complicated, you may want to get some help. But if you've got somebody who's got obstruction and all of the numbers there are fitting into that, you can probably go quite a long way to then decide whether or not this person may have asthma or COPD, and then consider a process by which you would confirm that diagnosis. So that's something that's probably very much in the realms of within general practice, within primary care, but maybe the other areas you might want to get some help and some advice. And I think the one thing to always remember, that normal there on the left hand side of the screen as you're looking at, if it's asthma you suspect and it's normal, keep thinking asthma if you think the evidence is there, because you can have normal spirometry even though somebody still has asthma. So let's go back to Sharon. Is there a case for antibiotics? So we've already had a conversation with her about why not. So she doesn't have a temperature. She doesn't have any visible or auditory signs of lung infection. She does have tachypnea, so it's a fast breathing rate, and tachycardia, a fast heart rate. So what else can we think of here? We could do C-reactive protein. That's possibly going to help us to make our decision, and we're now seeing increasingly that people can do point-of-care testing to help them make decisions about whether to prescribe antibiotics, or indeed you can do a white count. So for some of you, that might be something that's available within the health centre that you're working in, but for many of us, we may not be able to access these things. Could this airways obstruction be infection rather than an asthma response to a viral trigger? So that's a good question to ask. We need to think about whether that's a possibility. And then there's a question that you're asking yourself is, if I treat with steroids, and especially oral steroids, won't that make any bacterial infection worse? So I know from talking to colleagues that they do worry about whether they've got the diagnosis right, and that if somebody's got an infection rather than asthma and they give them steroids without antibiotics, then they may make the whole thing an awful lot worse. So this is one of the kind of conceptions that I think people have, and that impacts on their prescribing and their decision making when somebody presents in this way. So I think that's a good thing to maybe discuss, consider yourself if you're looking at this as an individual, but also consider discussing it in the group. Is this a belief that some of you have? How do you feel about the evidence there? Is it something that impacts on how you treat people? Okay, so remember that other question. What does Sharon mean by her inhaler? Okay, so probably it's going to be the SABA, probably, because that's generally, in my experience, what people mean when they say my inhaler. Hopefully over the years we're going to change that, and when they talk about their inhaler, they're generally going to be talking about something that prevents asthma. But I think these days, my inhaler normally means the SABA, and I'm sure a lot of you will agree with me on that. So what can we say? What conversation can we have? So Sharon, I hear from you that using your reliever inhaler gives you relief. I'm worried though that your airways are only 50% open, and that explains why you feel the way you do. Now I've said that 50% because if you went back through the slides, we had a predicted peak flow, we had a predicted FEV1, and then we actually had Sharon's levels. And in about both of those situations, it was about 50% predicted. So we are in the realms of moderate moving into a severe sort of situation with airways obstruction. So I want to communicate to her. And in this situation, I feel Sharon will understand what I mean by you've only got 50% of your airway open, and I'm sure she can understand that. What I can tell her is that I can give you treatment today that will start to unblock the remaining 50% and make you feel better more quickly than either the antibiotics or the reliever inhaler. So obviously what I mean by that is that I'm talking about steroids, and it's possible I'm going to give a very high dose of inhaled corticosteroid today, multiplying by 4 times the dose that we would normally give, or I might be giving her oral steroids if I feel she's more likely to be compliant or it's a reasonable thing to do in this situation. And the other thing that I do with patients, and I'd like you to click on this hyperlink in this slide, is it's a 2-minute film which has been developed within the NHS in England. We have a website called NHS National Health Service Choices, and this is an explanation of what's happening in asthma. And I found that this auditory and visual representation of the lungs and the airways and what happens helps people to understand and build on the conversation that I'm having with them. So it's a little bit more just to help me to make a case to my patient about what might help. So let's go to having had the conversation with Sharon, convinced her that it's not a chest infection today, but it's a flare-up of asthma that's been triggered probably by a virus that she's picked up from her children or from the children in her classroom. And what we're going to do is we're going to get some inhaled corticosteroid therapy to reduce that airway inflammation, to get her that 50% back again. And what I would want to do in this situation is stay close to Sharon, to keep her on board, to make sure that she's taking her treatment, to show her that she's improving, and to make her feel confident that things are moving in the right direction. So in the UK, for people who have an asthma attack, we recommend seeing them again in 2 days to check that they're responding and to also explore why this might have happened on this occasion and start to attend to any of the reasons for poor asthma control. But in Sharon's case, I may want to see her again in a week and again in another 2 weeks, just to check that she's responding, to keep closer to her, to show her that I'm treating her physical health seriously, which may help her to treat her own physical health more seriously. And I think importantly, the time that I might be spending now, which some people might say is a little bit excessive, what I would say is that if we don't spend the time now, we're just going to be spending the time unplanned, in an emergency, when it's harder to get stuff done. So I think that there's a real option here to really make a difference by spending time now. So as well as the inhaled corticosteroids, which I'm hoping are going to make a difference, and I will be able to show Sharon that they're making a difference, I can also help her to take steps to help her to live better with her asthma. Her asthma is not going to go away, but there are things that she can do so she can live better with it. So we can think about identifying symptom triggers. We can advise Sharon to avoid smoking environments, or indeed support her with her own tobacco dependency if that was the cause of the raised carbon monoxide. We can recommend regular physical exercise, and we can constantly review the inhaler technique whenever we see her to make sure that the medicine that we have prescribed is getting to the right place to make a difference. So why with Sharon was this situation right asthma care? Let's just reflect on what happened and why that was the right thing to do. And you can critique it, you can have a discussion, consider how you might have done it yourself. But it's right because I think what we did here was we used the extra time, or we used some extra time, because we needed to convince ourselves of the chronicity of her diagnosis. So she definitely got asthma. We needed to convince ourselves that we've got enough information today to be sure that it's an asthma flare-up, an asthma exacerbation, and not a chest infection. But not only convincing me, but I need to convince Sharon for her to do something different. And the other reason why it's right care is because I saw Sharon today, but I might not see Sharon the next time she comes in. And if my colleague, my pharmacist colleague, my nurse colleague, my GP colleague sees my notes, see what I've done, sees the measurements, sees the decision making, sees the conversation that's been had, it's going to make their life much easier the next time that Sharon presents, because they can repeat that material, they can reflect on what was found before. why else is it asthma right care? And I think that the case is or isn't stronger for asthma, and importantly, if it is strong for asthma, by showing a response and reversibility, you can support better to optimise lifelong preventive therapy. It not only helps her, but it's also going to help her children as well. She's going to think differently about her asthma after this particular episode. I hope she's going to understand it better, and it won't just be one episode. We talked about seeing her at 2 days, maybe 1 week, maybe 2 weeks. So it's putting the time in now, working with her about what is causing it, why it's happening, what reverses it, is all going to help her to manage herself better in the future. And this is a nice slide which has been developed by Gina, which just helps us and just to remind ourselves of the huge range of things that can trigger asthma. So I think we often go to the hay fever related asthma, so the flowers, the pollen. We'll think about animal fur, we'll think about dust, but there's lots of people that will come up with other things that we may not often think about. Stress is a real risk to developing worsening asthma. We see more and more evidence around air pollution. And of course, a lot of you will see patients coming in who are really struggling at work because they're in an air-conditioned office. So there are other causes of, or other triggers for asthma as well. We talked about getting better asthma control, and one of the really important things is getting the inhalation technique right. We know that a lot of health professionals get it wrong, so it's very important that we know what we're doing in order to help people to know what they're doing. So always good to make sure that they've brought their inhaler with them. They need to demonstrate, we need to be able to see what their errors are. We can help them with some aspects of it, importantly explaining why it's an error and why it impacts on the medicine that they will get into their lungs. It's great if you can use videos because, and I find this personally, that if I'm showing someone else showing the same thing that I'm recommending, it somehow validates what I'm saying as well. And I think making sure they always bring their inhalers and doing it every time is really, really important. So from here, I'd just kind of like to tell you a little bit more about the whole Asthma Right Care movement for global change. So we've talked about Sharon, we've talked about asthma guidelines, and this is all kind of to paint a picture of that there is probably a right way of doing things and a wrong way of doing things, and we're all health professionals that are human, and some days we do things more right, and sometimes we do less things right. But this is a movement to try and get a real change in the care of people with asthma. And as we've discussed already and shown from the evidence in the earlier slides, people tend to be over-reliant on reliever therapy, and it has an impact. It means more urgent care, it means more deaths. So there is a real burning platform here that we do something about that, and we move from reliever-dependent asthma management to preventer asthma management, which can really make a difference. And so that's what the Asthma Right Care movement for global change is all about. And we've developed it as a movement because we want people to think differently about it, and we want people to get excited, to sort of join the group, join the band, and start to make a difference. We know that every system is perfectly designed to get the results it gets, from Earl Conway and Paul Batalden, and we work in systems that are designed to get the results it gets. So if we don't take time out with Sharon, if we don't take that consultation a bit differently, if we decide, no, I'm not going to give the antibiotics, I'm not just going to give the reliever, I'm going to work through this in the right way, in a systematic way, and we change the system that we work in, we are much more likely to get a better outcome. And I hope you can see from the Sharon case that it's about challenging yourself to work differently. But what I would also say is that in that situation, and many of you will have 5 or 10 minute consultations, it is the system that stops you from doing the right thing. if the system allows you to have a 15-minute consultation or a 20-minute consultation, it's much more likely you're going to do the right thing with Sharon and get the right results. So it's not only about you putting the personal effort in to behave differently in your consultation, but it's actually about the system helping you, and maybe as part of the movement you can help change the system where you are so that you get the right amount of time to help people like Sharon in the right way. So a little bit more about how we are making a case for change. So we have worked in the UK with somebody called Sir Muir Gray, who is a physician and public health expert, and I think in the situation with asthma, we've got all of the features that means we have to do something different. So there's unwarranted variation. So some people control their asthma well, live very well with it, but there are others who are dying from it. We are getting harm from overdiagnosis of asthma, from overtreatment of asthma. We are failing to prevent a disease and disability because we're not getting airways inflammation under control early enough in people's lives. And there is a huge amount of waste, the resource of the health professional, the work activity of the person that's got asthma, and also it's very inequitable. Not everybody from all socioeconomic groups, from all ethnic groups, from other groups where there is traditionally problems with equitable access to healthcare. All of this happens in asthma, and so therefore there is a real case for change here and a need for this movement. And we've talked about the constraints as well. So financially, it's tricky. Asthma is a high volume problem. Maybe 1 in 11 people suffering from asthma. That's a big resource requirement for your health system. People are expecting more personalised care, and we talk more about asthma being needing to be personalised because there are different types. We've got issues with climate change, air pollution, and it seems that we've just got an increasing need with asthma as well. So there's a very strong case here for doing something and having this social movement. We've kicked off with this movement because of various hunches. We know that people are worried about the overuse, the over-reliance of short-acting bronchodilation. We recognise that the very first conversation you ever have with somebody about asthma tends to be associated with a reliever. So we give people a reliever because they're feeling unwell, and there is something about that messaging about it's the blue inhaler in the UK, but the SABA that's the most important thing. We have hunches that people don't necessarily treat asthma seriously. Even though we have a high number of deaths of asthma in the UK, the amount of deaths experienced by an individual healthcare practitioner in primary care is so low that it doesn't seem to really feature as a high risk for them. So there's a number of things there that we feel is out there, that we've got hunches about, and we feel that people want to do something different about this. So we've looked elsewhere about how people get changed, and there's some references here that are helpful for you to read, which have come from a set of slides that were developed by Sian Williams, who's the chief executive of IPCRG. So we've been looking through at the Lancet, we've been looking at large-scale change, and we've been looking at Nesta and thinking about how we're going to make these changes. We have a definition here from the editor of the Lancet in 2017 that tells us a little bit about what they think right care is, and that there are important categories for us to consider. And so when we're doing our asthma right care, case for change, our project, our movement, and we need to think about money, finance, how the organisations are working. We need to think about knowledge, beliefs, assumptions, bias and uncertainty, and also power and human relationships. And I'm sure that all of you can think about what impacts on asthma care where you are. A lot of you'll immediately see where the financial restrictions are, how organisations work in a particular way which stops you from doing the right thing, that we have problems with what people believe, culturally what people think asthma is, whether people feel embarrassed about asthma, feel embarrassed about using inhalers, what are the doctors' beliefs about it. So there's key things here in the kind of this definition of right care that we can see that are relevant to asthma right care too. So we have I think a great case for change. We have a high burden of disease. We have overuse of relievers, underuse of preventive therapy, and there's clearly a case to start moving on with this. What we think right care is, and what I hope you'll have seen in this case with Sharon, is that it's about doing the right things and only the right things in the right way, for the right people, at the right time, in the right place. That really depends on whatever your local context is, what resource you've got available, where you see people, who sees people. But these are some of the basic things that are right care. And the thing is, if we do right care, then we increase the chances that we're doing value-based healthcare. Okay, so it's something that really makes a difference, not just to the individual, but makes a difference to our system and to our public purse as well, and how we're paying for healthcare too. So what we want to do is to sort out asthma care once and for all. We want the healthcare system to ensure that it's the same for everybody, regardless of their background, regardless of the characteristics of that particular individual. And there is something that we can do about it. And so our first phase is about the over-reliance of SABA. And we've explored that today with Sharon, and that's something that we are now taking ahead. What we would like to see is a shift in the practice average ratio of reliever to inhaled corticosteroid inhaler prescribed in a year. So where the ideal ratio is 1 to 6, so for every 1 SABA you will have 6 inhaled corticosteroids, but at the moment it's much more likely that people are using 2 short-acting beta agonists for every ICS. So hopefully that makes sense to you, and that we need to shift the ratio from reliever towards preventer. What's always really important in a social movement is, so that you can talk about the initial group at IPCRG who've come up with the ideas and developed some of the materials, but this will not work if we don't get people to follow us. So if you're listening to this slide set, it means that you're probably somebody who's engaged enough to be one of those followers. And so maybe have a look and see what we're doing. Stay attached to where the movement is going, see what's going on the IPCRG website, and help us to get that message further out there, because more people who are talking about this in a particular way, thinking about this in a particular way, the more likely we are to get spread, and we're likely to get change. So we've been doing the Getting Our Social Movement going for quite a while now, and we've started this off in a number of countries. We've created some leaders, we've had some meetings, we've come up with some tools, we've had some of those conversations precipitated by using the question cards, and we're now kind of moving it from country to country and getting more people involved. This is a very complicated slide which you can have a look through, but what we're looking at here is the way that the Asthma Right Care project is beginning to work to get the messages out. On the right hand side of this slide you can see the asthma slide rule, which is a really great tool for having conversations with colleagues or with patients about what 6 inhalers means per year. I mean, how many puffs of salbutamol is that? How many breathless moments is that? Question cards we've got here as well, which have already talked about to you. So as you can see, we started off with UK, Canada, Spain, Portugal. In the last year, we've now started to get interest from Argentina, Mexico, Brazil, Ireland, and some of the countries in the Gulf. We're getting some of the materials changed into other languages, we're learning about other cultures, and we're hoping to develop this further into the Netherlands, Greece and France. So this is a building, moving a beast at the moment, and we're, if you're looking at this slide set, we're hoping you want to take part in it as well. So a little bit more detail, you can see here the information about the asthma slide rule, and you can see the question and challenge cards, and we've got lots of information on the website to help you with that. So far, we've reached 10,000 frontline healthcare professionals. We've been to 4 international conferences, multiple national conferences, and there's a number of materials which are developed, being improved, being translated. So do go and have a look at those. A couple of quotes here. Mar and Claudia, GPs from Spain and Portugal, who've been working on this now for a few years, noticing that it's really making a difference in their countries and into their own practices. So let's get it out there a little bit more. You can learn from the stuff that we've learned. Be brave, get out there, talk about the numbers, talk about the case for change, the ratio, it's wrong, we need to move it from reliever to preventer. Be passionate about making sure that everybody gets the same access to this care, taking the medicine seriously, making sure that people remain safe. That's a responsibility of us as healthcare professionals as well. We've learned a lot about words as we've been working over the last couple of years. So I've used interchangeably a little bit in this session over reliance and overuse, and I think over reliance seems to be a much better term, though we probably have a tendency to use the term overuse. Important that we distinguish between short-acting bronchodilation for asthma versus for COPD. So there isn't a problem of over-reliance for COPD per se, because bronchodilation is a key treatment for people with COPD. So important to differentiate that. Doses and puffs, so 2 puffs makes a dose, so to kind of get your messaging right on that. Rescuing or relieving, stops asthma versus stops asthma attacks. Let's get rid of as directed by your GP. Let's be more specific. Let's not say as needed. Let's talk about what it means. And as I mentioned earlier on, taking a puff means you're breathless. And if you're having 12 inhalers a year, that's 2,400 breathless moments in a year, which is quite shocking. And what we've really learnt and really benefited from, I'm speaking as a GP, but working with our pharmacists, the people who dispense the material that we're trying to get people to take, is absolutely vital, and we've had some great collaboration and development of the project with our pharmacists. And in this slide, we just kind of want to share with you really about why this is different. So, you've all been to education sessions, you've all been to lectures, you've learnt about the stages of management in asthma, step 1, step 2, step 3, etc. But why is this different? And I think, what we're doing here is that we're working with people, having conversations, learning, feeding back, spreading it. So it's a very different approach. It doesn't have the formality of a lecture, of a guideline, and it's allowing people to think for themselves what is the right thing for them to do locally. So the question cards, the asthma slide rule, it didn't exist before we did this. But the conversations that we had as those early countries allowed us to come up with these concepts, these tools that allowed others to have the sort of conversations that we started to have once we started to think differently. This is a interesting slide which talks about the COM-B model. So this is a behaviour change model which is described by the team at University College London. And COM stands for the capability. So you as a health professional, a patient, needs to be capable in order to have a behaviour change. you need to have the opportunity in and be able to make that behaviour change, and you need to feel motivated to have that behaviour change as well. So that's kind of one of the models that's always been in the back of our mind whenever we've been thinking about how we're going to get change in our health professionals, get change in our followers, and it's about thinking more deeply about why people don't follow the guidelines. Is it because they haven't got the time to do it, or they haven't got access to it, or they don't see asthma as particularly important? So that picks up on all three parts of the COM-B. The capability, the opportunity, the motivation. So it's worthwhile thinking about those things when you see your colleagues or you see your patients not following the advice, not following the guidelines that have been given. So what we have here on this slide is a description of why the prescribing is not right. Thinking again, you can see the capability on the first point there, which is the C. You can see opportunity around lack of access to the right medicine, which is maybe not such an issue in the United Kingdom, but may well be an issue in some other countries as well. So there are lots of potential areas that stop people doing the obvious thing, following the guideline, doing what the doctor said, because of all these different factors. Dispensing here, something that we've learned from our pharmacists, one of the things that is still out there is that you first take your short-acting beta agonist to open up the airways, and then you take your inhaled corticosteroid. Now we know that's not right, but people are still giving that wrong advice, and that's really a capability issue. Have people been updated? Where is the education coming from? Are people being exposed to the right information? And with our patients, we need to think about where they're at in terms of their motivation. So Sharon, her motivation was keeping her family safe, keeping her family going. So her motivation around asthma management may not have been as great as some of the other things in her life. So it just, how risky was her asthma in her life compared to the potential violence from her partner? What does she believe about the medicines? Is she worried about steroids causing harm to her, steroids causing harm to her children? It's, these are important things that we need to understand to get Sharon to behave differently. So a lot of information there, and working with patients as part of our ARC social movement, we've understood a lot about what might be happening there. So, who wants to help us deliver better asthma care? Well, I hope this slide set has given you some ideas about how to do things differently, what might be right care, how we've been developing the movement so far, and it would be really great for those of you that are looking at this slide set to think about how you want to move on from this, how you want to join us on the social movement, how you would like to be a follower, and you can find out much more about what we're doing on the IPCRG website on the Asthma Right Care page. There are some additional resources for you to look at on this slide, but also as part of the IPCRG website page. So we've got some material that helps to describe and helps to visualize what's going on and why asthma is an inflammatory disease. Information about the paradoxical reliance on SABA at GINA step 1, and information about why that is happening. We've got some control tests here. So there's one here around control of allergic rhinitis and asthma test. We've got the asthma control questionnaire. Some information here about how to do allergy testing and how that helps you to understand people's triggers. GINA is the guideline globally, and therefore something to keep a very close eye on. In 2019 it was updated, so always go and have a look at the latest one. We've got GINA step 1, 2, 3, 4, 5, which you can have a look through, and as I say, keep updated because it changes year on year. Maybe have a look at also personalised asthma action plans. Part of helping Sharon to change was education. Sharon has a difficult life, and therefore making sure that what needs to happen in a crisis is written down so that it's easier for her to do the right thing. We know that it makes a difference in terms of decreasing healthcare resource and preventing admissions. So it is something that's definitely worthwhile doing, and there are some materials available. Here are some that have been developed in the UK. Here is one for adults from Asthma UK, and here is one from children. So again, something to consider using. That is the end of the slideshow. Thank you very much for spending some time, having a listen to what we're doing with Asthma Right Care, and I hope this is going to be valuable, and I hope that we see more of you join the Asthma Right Care movement. Thank you. Bye-bye.